to solve. All right. So yes, already. And our shared mission is that together we form the backbone of Ghana's healthcare system, and we serve millions of patients across over 3,500 plus, or over 3,500 health facilities nationwide. I'm talking about Ghana. And our focus today here is to lay the foundation for All right, please, can you hear me?
Yeah, we can hear you now.
All right, thank you. So we hope that this session will give us knowledge in the sense of we being able to understanding the burden of healthcare-associated infections in Ghana, and be able to describe the chain of infection and how to break it, and then also be able to explain what the Ghana Health Service IPC standards and WHO guidelines are. Aside that, we also hope to be able to develop skills in proper hand hygiene technique, and then also how to select and use appropriate PPEs for different scenarios, and then be able to also implement standard precautions in our own specific professions. And then also we should be able to perform safe risk segregation and shafts management. So at the end of it all, we need to apply whatever we are going to learn. So we hope that we'll be able to conduct an IPC risk assessment in our work or in our own work area, and then also develop a profession-specific IPC action plan, train our colleagues on best IPC best practices, and then also contribute to the facility-wide IPC improvement. So why does IPC matter, or infection control, prevention and control matter? Now in Ghana, we have some phenomenon in our healthcare systems that we call healthcare-associated infections. And then we also have a subsection of it, which is called nosocomial infection, which is hospital-acquired infections. However, as we'll get to know, we know that we don't render all our services within the hospital setting. Some are rendered in homes, and then as well as other locations. And so the statistics show that about 15 to 20% of our hospitalized patients develop these healthcare-associated infections. And then also, patients who find themselves in ICUs, about 30 to 40% of them also get affected by these kind of infections. And then we have over 50,000 deaths, which are actually preventable. And these occur as a result of healthcare-associated infections. And we spend over 500 million Ghana cedis as a result of people being hospitalized for a much longer time than they should have due to these infections. And if we are ranking the various types of infections, surgical site infections rank higher or highest, followed by bloodstream infections and then urinary tract infections, pneumonia, and then tuberculosis transmission, which most of the time we have over 60 cases occurring per year, even among healthcare workers. Now, we also find ourselves in a country where various diseases are endemic, like malaria, HIV/AIDS, hepatitis B. And then now even the scariest part of it is the increasing rise or the increase of these multi-drug resistant organisms. Because if you have an infection and the antibiotic you are being administered or you are giving cannot kill the bacteria, then it means you are done for. And we need to know that when we are going through some of our practices to curb infections like disinfections and all that, if we don't do them properly, some of these organisms, they only get weakened because we didn't use the right concentration of the detergents or the disinfectants. And so these organisms actually were not properly killed. And sometimes when they don't get properly killed, they are able to, come back stronger. and build defense mechanisms that will not allow those same disinfectants to kill them the next time. Now, COVID-19 hit us, and it actually came to, expose our nakedness in terms of infection prevention and control. So during the COVID-19 pandemic, we had over 2,500 healthcare workers infected. Within the first 2 years, we had over 35 deaths among healthcare workers. 40% of facilities also lacked adequate PPE in the initial stages. And then we also realized we had limited isolation facilities across the nation. But what did we also identify as the gaps in our infection prevention and control practices? So realize that we had, not less than 40% of our facilities or people within our workers within our facilities not being compliant in terms of hand hygiene, or not being consistent in terms of how they perform the hand hygiene. And we also realized that there was poor respiratory hygiene practices, inadequate environmental cleaning protocols, limited IPC training for allied health professionals, insufficient PPC stockpiles, and then we also had weak surveillance systems. So following all these things, at least we learned something, and out of that, we were able to increase awareness on the importance of IPC. And then more investments were put into, procurement of PPEs and then other supplies. And then facilities also now began to form IPC committees. And then there were now enhanced cleaning protocols. And due to, the nature of the pandemic, where we were not meeting physically, and then also having to engage in, safe distancing and all that, telemedicine was adopted. And then also hand hygiene stations were placed at entrances of various facilities. So it's important that we should sustain all these improvements, not only because of COVID-19, but, to protect all of us against infections. So Ghana Health Service has an IPC framework. And this was actually, written in 2020, but updated in the year 2023. And it has core components. And these core components include standard precautions, which are to be applied to all patients all the time. And these include hand hygiene, PPEs, respiratory hygiene and cough etiquette, safe injection practices, safe handling of contaminated equipment, environmental cleaning and disinfection, waste management. And then we also have transmission-based precautions, which include, contact precautions, as well as droplet precautions, airborne precautions against like TB, measles, chickenpox, etc. Then IPC governance. So we now had facility IPC committees becoming mandatory. And then focal persons were also designated for infection prevention and control. And then annual IPC training became mandatory as well. And then various surveillance and reporting systems were also put in place. Now, under occupational health, hepatitis B vaccination was also made mandatory for all healthcare workers. And then post-exposure prophylaxis protocols were also put in place, as well as health worker safety programs were also put in place. So there are some WHO Afro IPC standards for Ghana. And it has about 8 components. So the first are the IPC programs at the organizational level. And these include, having a dedicated budget and resources, having IPC champions in each department. Now, IPC guidelines were also put in place, which include evidence-based, locally adapted, guidelines. And then IPC education and training to involve mandatory, IPC training for all healthcare workers, as well as annual updates and competency assessments. Then we also have the health associated infection surveillance. And this include monitoring infection rates, receiving feedback from health workers, and among many others. And then also we have multimodal strategies. So in this case, there were system changes. So the system changes were to make things easy to do the right thing. And then education and training, monitoring and feedback, reminders and communication, safety culture, were always being, projected all over the place. And then when it comes to monitoring and evaluation, to compliance audits were being carried out, and then outcomes were also always being measured. Now, workload, staffing, and bed occupancy, also a very important component of this, involve, adequate staffing levels and then appropriate patient to staff ratios. Now, various, facilities and equipment were also put in place, like hand hygiene facilities, isolation rooms, and then making sure that there were adequate supplies. Now, it's important to know that when it comes to infection prevention and control infections, there is always what we call a chain of infection. And this is to help us understand how infections spread. So there are 6 links to this chain of infection. So the first one is the infectious agents. So this can be bacteria, viruses, fungi, parasites. Then we have the reservoir, which can be humans, animals, environments, equipment. Then we have the portal of exits, as in how the organism leaves the area where it thrives to get into a human. So this can be blood, respiratory secretions, urine, feces, skin, etc. Then the mode of transmission is about how the infectious agent travels. So this can be through contact, droplet, airborne, vector, among others. Now, after this infectious agent is out, how does it now enter the human or the human host? So this could be through the mucous membranes, broken skin, respiratory tract, among others. Then finally, a susceptible host. That is a person who can, be infected. And these mainly include immunocompromised people, elderly people, people with chronic disease. So then what will be your role in breaking this chain? And let's note that any one broken link stops infection transmission. So we have hand hygiene. Hand hygiene will break transmission. PPEs will block portals of entry or exit. Vaccination will reduce susceptible hosts or reduce the number of susceptible hosts. Disinfection will eliminate the reservoir. And then isolation will interrupt the transmission. Now, hand hygiene. Hand hygiene is a single most important IPC measure. And so WHO have 5 moments for hand hygiene. That is, when should you perform hand hygiene? So before touching a patient, before cleaning or an aseptic procedure, after body fluid exposure risk, after touching a patient, after touching patient surroundings. So in terms of effectiveness, proper hand hygiene has been shown to reduce infections by 40 to 50%. And it costs less than 50 pesos per patient contact. And the most cost-effective, it happens also to be the most cost-effective infection prevention control intervention. So what are the reality checks within our healthcare setting? So current compliance is ranging from between 30 to 60%. I remember when I was in the Tamale Teaching Hospital, I was part of the infection prevention and control team. And we carried out a number of surveys, and it includes every part of the hospital, from wards to offices. Yes, the offices, you don't have patients going to offices, but then, or patients being taken care of in offices or taking any sample to offices. But we had to go to offices as well, including the chief executive officer's office. We had to go to the mortuary. We had to go to the pharmacy. We had to go to mobile pharmacy vans. Everywhere, name it, we had to go there. Now, the goal here is that we should be able to increase, compliance to more than 80%. But then what are the main barriers? We don't have enough sinks, not enough soap, not enough alcohol-based hand wraps, lack of accountability. And even sometimes people are using some of the, these alcohol-based hand wraps in the wrong way. They didn't know even when to use these alcohol-based hand wraps. As well as time pressure. So we now want to look at the WHO six-step method. WHO six-step method. So this is the proper technique for hand hygiene, and it should take between 20 to 30 seconds. So the first step is that you wrap your palms together, right palm over left dorsum, interlace fingers, and vice versa. Then you do the palm to palm with your fingers interlaced, and then you also do the backs of the fingers to opposing palms with fingers interlocked. You do the rotational, rubbing of right thumb clasped in left palm, and vice versa. And then you have the rotational rubbing backwards and forwards with clasped fingers of right hand in left palm, and vice versa. So what are some of these hand hygiene products that we have to make? Soap and water. If you are using soap and water, washing your hands should take between 40 to 60 seconds for you to do a very proper hand washing. And then if you are using the alcohol-based hand wrap, between 20 to 30 seconds, it should be done. But then what are some of the, common mistakes to avoid? Okay, before I go to the common mistakes to avoid, when should you do even hand hygiene with your soap and water? This should be when your hands are visibly soiled or after the use of the toilet. And then if you happen to be exposed to Clostridium difficile infection, you should also wash your hands. And then before eating, very important. Then when it comes to the alcohol-based hand wraps, all other clinical situations, apart from what I've mentioned for when you use the soap and water, you should apply alcohol-based hand wraps. And then it is also the preferred method when your hands are not visibly soiled. And then it is also more effective at reducing bacteria because of the alcohol. So some of the common mistakes to avoid is, skipping thumbs and fingertips when you are performing the hand hygiene procedure, or doing it for less than 15 seconds, or not drying your hands completely, and then using hand wrap on visibly soiled hands. And then also wearing jewelry, which can actually, trap bacteria. So the take home here is that you can't see germs, but with the proper technique, you can remove them. Next, we move on to personal protective equipment. So these are specialized equipment which we wear to protect against exposure to infectious agents. And the key principles include: one, hierarchy of controls. Here, the personal protective equipment is actually your last line of defense. So there are various things that, would bring about your use of these personal protective equipment. And usually you use it when all the other kind of controls you can use to protect yourself are insufficient. So if you want to select any personal protective equipment, your selection should be based on the route of transmission of the expected infectious agents, the type of procedure that you are performing, and then your level of exposure, as in what you're anticipating, how much you're anticipating you'll be exposed. Now, the standard PPE components include gloves. Gloves will protect your hands from contamination. Then gowns and aprons will protect your skin and clothing. Masks or respirators would also protect your respiratory tract. Eye protection would also protect mucous membranes. And then your face shields will also protect your face fully. But then we have challenges in Ghana when it comes to the use of PPEs. So we have insufficient supplies, especially in rural facilities. Also, depending on the type of PPE you are wearing, you can also, find yourself not being comfortable because of the amount of heat. I remember the days when we were working in the COVID lab, where we have to put on something like what is shown here. Let me just use. Sorry, I forgot to put it in PowerPoint mode as well. Really sorry about that. Yes. So during the times we're working in the COVID lab, we have to dress up like this. And of course, you can imagine the heat if the place is not well, air conditioned. And then we also have various storage and distribution issues. So solutions to some of these were that we needed to prioritize high-risk areas. And then also we needed to, learn the proper donning or doffing, to extend the PPE life. Because if you contaminate your PPE to a certain extent, you can't keep on using it. And then also there were reusable options. So you have cloth gowns, which maybe could be washed. You also have washable face shields. And then also we need to strengthen our local manufacturing company so that they'll be able to produce these. And then also we need to look at more stockpiling strategies to help us. So here we have various scenarios, that would inform what kind of PPE you need to put on. So when you are doing a routine patient contact, yes, you can wear gloves. You can wear the apron or gown if you are likely to soil yourself. You don't need to wear a mask. You don't need to wear eye protection. You don't need to, you just have to employ standard precautions. However, if it's a routine patient contact, but the patient happens to be coughing, then you may need to be in a mask. And you may even need to also be in eye protection. So depending on what exactly you are to carry out. So for example, if you are cleaning a blood spill, gloves, you need to use the heavy duty type of gloves. You also need to use the waterproof gown or apron. You need surgical masks. You also need to use some eye protection, a face shield, or the goggles. And then also, in the case of blood, you could get an infection transmitted through contacts or splashes. So there are various scenarios which would inform whether the type of PPEs that you have to don. Now, so here we have some guidelines for particular cases, and this is Ghana specific. So for medical laboratory scientists, gloves are mandatory for all specimen handling. Splash shields at centrifuge stations, but between myself and you, we know that we don't use them. Then N95 for TB culture work, which we still don't see our people wearing them. Now for physiotherapists, gloves will be needed for wound care and the handling soiled linens, apron for contact with body fluids, as well as mask if the patient is coughing. And then for radiographers, they also need gloves for positioning infectious patients. They will need lead apron plus a disposable gown for TB patients. And then they also need mask for respiratory symptomatic patients. So when it comes to donning and doffing of the PPE, so if you say doffing, it means taking off the PPE. So these are for, we need to look at the critical, procedures in terms of the proper sequence of putting on your PPEs. So if you are, you are from a clean area and you are moving into a dirty area, hand hygiene is a must. Then you gown, and in the gown you have to tie at the neck and then the waist. So there are two levels of gowning or tying your gown. And then the mask or respirator should also be one that molds to your face, as in it's able to cover the sides of your face well. And then also the goggles or face shield should also be positioned properly over your eyes. And then the gloves should be pulled up to cover the cuffs of the gown that you are wearing. And some errors that we do that could lead us to, getting contaminated is when you touch your face with the contaminated gloves, or you remove the gloves in an incorrect way, or you touch the front of your mask. There's no way you should touch the face of your mask with your gloves on. And then skipping hand hygiene also between steps, as well as using single-use PPEs. Yes, so if the PPE is for single use, but most of the time, because of the limits, the limits in our resources, we find people reusing, the PPEs. Now, when it comes to taking off the PPEs it's important to start by removing gloves. In this case, you have to turn the inside out and so that you don't contaminate your hands. And then after that, you perform hand hygiene. So if you were in gloves and they were heavily soiled, you need to perform hand hygiene. And then to remove the face shield, you remove it from behind and then you place it in a container. And then to remove your gown you also remove it from the inside and then you roll it out to cover the contaminated side inward. After that, you have to perform hand hygiene again. Then in removing the gloves, you also remove it from behind. You don't hold it from the front. You hold it from behind to remove it. After that, you perform hand hygiene. And then you remove your mask. That one too should be done from behind and not from the front. And then you do the final hand hygiene. So it is very important that to prevent, self-contamination, you should perform hand hygiene between all these steps. So when it comes to the donning and the doffing, it's important that you practice until it becomes, kind of automatic. Because sometimes when you are unaware of yourself, you will be removing or either putting on or removing your PPEs, and you may unconsciously not pay attention to all these important steps. But then if it is something that you practice a lot, you realize that it will become automatic and you are not likely to make the mistake of forgetting. Now we move on to respiratory hygiene and then cough etiquette. So why does this matter in Ghana? We have a lot of, respiratory infections in Ghana, TB, pneumonia, influenza. And then we also have a lot of crowded waiting areas in our facilities. And we have, limited ventilation in older buildings because of the design. And then during the rainy season too, we have an increase in the transmission of respiratory infections. So what will be our standard recommendations? Now, for all patients and visitors, we have to make sure that they cover, or we need to educate them that when they should cover their mouths when they are coughing or they are sneezing. And they can use tissue or the inner elbow, not their hands. They should either use tissue or the inner elbow. And then they should dispose of the tissues immediately in the designated bins, not on the floor or on chairs. And then they should also perform hand hygiene after coughing or sneezing, either with soap and water or with the alcohol-based hand pump. And then they should also wear surgical masks if coughing. And this should be provided at the entrance of the facility. And then they should also maintain distance. At least they should stay more than 1 meter from others when they are coughing. Now, for health workers, we need to model proper behavior. And then patients should be educated when they arrive at facilities. We should provide masks to patients who are symptomatic. And then we should also separate coughing patients from the others. And there should be adequate ventilation in the waiting areas. Yes, these are the ideal things that we need to do. Now, we can also, implement some of these things at a low cost. And this can include, providing signage in English as well as local languages. There can be visual posters, especially for the pictures for those patients who are not literate. I remember that at the I think the whole teaching hospital, some years back when I came to do internship, I was doing my internship, they had such signboards which says that you cannot spit here, written in Ebe, written in Gan, and I think written in Tree. Sorry. And then there should be tissue boxes at registration desks. There should be waste bins at the waiting areas, free masks at entrance so that, symptomatic patients can be given, and then designated cough corners in waiting areas so that when someone feels like coughing, the person will just go to that side and cough. And then there should be open windows for, natural ventilation. Now we move on to another important area, sharp safety and needle stick injury prevention. So we have a high burden of these sharp injuries in Ghana. So the statistics tell us that about 1 in 3 healthcare workers experience needle stick injury during their career. 60% go unreported due to stigma and then lack of protocols, and then also risk of infection. For hepatitis B has been like 6 to 30%, hepatitis C being 1.8%, and HIV about 0.3 percent. So the most common causes include recapping of needles, which forms about 40%, and then improper disposal, which comprises about 25%, then passing sharp instruments, and then cleaning up or handling waste. So this one happens a lot to the cleaners and the oddlies, and then collision with colleagues. So when it comes to prevention or having some strategies to prevent these, it can start with some engineering controls. So here we can use what we call retractable needles. And then also there should be puncture-resistant sharp containers at various points of use. If we can, we should use needle-less systems. And then when it comes to the work practice controls, don't ever recap needles. If you recap a needle, employ what we call the one-hand scoop technique. If you need to pass an instrument which is sharp, you can place it in a kidney basin and pass it over, not hand to hand. And then also, if you expose or you expose a sharp object and it's not to be used immediately, just dispose it. And then don't also remove needles from syringes manually. And in case you are carrying a sharp object, just alert others on the way that you are coming with something sharp, so they should be careful. And we can also have administrative controls, such as training on safe practices, hepatitis B vaccination for all staff, and then post-exposure prophylaxis protocols, as well as reporting incidents and being reviewed. So we have Ghana-specific challenges. So these include, safety devices being expensive and in limited supply. But then in terms of being able to solve that, we can prioritize high-risk areas, such as the phlebotomy or the surgery or the surgical theaters. And then we should also train on safe practices, with conventional devices. Another challenge is sharp containers often not being available. I'm just talking about Ghana-specific challenges. And maybe to solve that, we can have these locally made puncture-proof containers. And these are like thick plastic bottles with small opening and clearly labeled. You know, we have these water dispenser containers. They are quite thick. The container is quite thick. And I think those can be customized and used as sharp containers in places where they don't have. So what do you do after a needle stick injury or exposure? So here we look at the post-exposure prophylaxis protocol. So there are some immediate action that should be taken within minutes. So if you have a percutaneous injury, you have to wash the wound immediately with soap and water, but don't squeeze or scrub aggressively. Then you quickly report to your supervisor and then you seek medical attention. And you shouldn't delay at all when it comes to that. Now, for splashes to the eyes or the mucous membranes, you have to irrigate the site copiously with water or saline for about 15 minutes, and then report and seek medical attention. Then you have to go for post-exposure assessment. So, first of all, you have to determine the type of exposure, whether it is percutaneous, mucous membrane, or broken skin, and then the source patient status. Maybe it was a sharp that was used to take a sample from a certain patient, but you don't know the person's status with regards to HIV, hepatitis B, hepatitis C. And then the worker who has also been, exposed, we also need to check the person's vaccination history as well as immune status. For example, if you have been vaccinated against hepatitis B, we need to know whether the antibodies have actually been formed in you yet. Now, let's look at infection-specific, post-exposure prophylaxis. So we start with HIV. So that should start within 2 hours. But then, if you can start sooner than that, it's better. So, sorry, I didn't write in full the names of these drugs. But then, of course, these are things that when you visit the designated clinician to take care of post-exposure prophylaxis, they are going to put you on. And then after that, so there should be baseline testing and then follow-up testing. At the very day that it occurred, they need to test you 6 weeks after you need to test 3 months, 6 months, you need to test. And usually this is available free of charge in all designated PEP centers in Ghana. And when it comes to hepatitis B, if a worker is exposed and that worker has not been vaccinated, they first of all have to administer hepatitis B immunoglobulin, and then they also start the vaccine series. If the person has been vaccinated, we need to know the response. If the person has been vaccinated, we need to check whether the person has produced antibodies against the virus. If it is positive that the person has produced antibodies against the virus, then there's no treatment needed. But if the person has been vaccinated, but we don't know whether the person has produced antibodies yet or not, we need to check. We need to confirm whether antibodies have been produced, and then after that, we can know what to do next. Now, when it comes to hepatitis C, there's no post-exposure prophylaxis available. However, we need to monitor for seroconversion and then treat if the person has been infected. So seroconversion simply means the body being able to produce antibodies against the virus. And then, very importantly, we also need to report and document. You need to report and document. So you need to complete an incident report form, and also we also have what we call the confidential log that also has to be completed, and then a root cause analysis to prevent future incidents need to be noted. right. Next, we want to look at environmental cleaning and disinfection. Environmental cleaning and disinfection. All right. So here we want to look at environmental hygiene. And this is important because various pathogens survive on, various surfaces. And some of these infectious agents have been known to survive for a certain minimum period of time. So, for example, Clostridium difficile can be on a surface for up to 5 months. Methicillin-resistant Staphylococcus aureus can last up to 7 days, and then norovirus can be there for weeks. So some of these environmental contaminations are able to contribute to about 20 to 40% of these, healthcare-associated infections. And then also high-touch surfaces also give high risk. We say high-touch surfaces, we are looking at surfaces that people easily, come into contact with. And so those surfaces are the surfaces that can give people a very high risk of, getting contamination. Now, when it comes to cleaning and disinfection, we need to understand the difference between cleaning and disinfection. So cleaning simply means you remove visible dirt, that's debris, and then you also, reduce the microbial load by about 80%. And this one, soap or detergent and water is enough. And this should be done before disinfection. So what it means is that if there is a black spill or something, you need to do some cleaning before you move on to disinfection. And disinfection will kill most organisms, most microorganisms. And here chemicals are used, and it will require contact time. But this one will vary by products. It will vary by products. And then also, usually this disinfection is only effective when you do that on clean surfaces. If there are other things in the environment, they are actually going to, impede the activity of the disinfectants. So various areas that need to be disinfected or cleaned we need to know how often that should be done. So for the high-touch surfaces, you clean and disinfect at least twice daily. And this includes bed rails, IV poles, doorknobs, light switches, phones, keyboards, etc. And then you have the patient care areas. So in between patients, you also do the cleaning. And then the floors must be cleaned daily. But then if the place is visibly soiled, you need to clean. And then for the toilets, they need to be cleaned and disinfected at least twice daily. So here we have some examples of some common disinfectants, and then how they are that we use in Ghana. So the most common is what we call the bleach, which is just chlorine. So it's used for general surfaces, blood spills, and the contact time is 10 minutes, and it's fairly cheap. Okay. Then you have the alcohol, which is usually 70% ethanol or 70% isopropanol, and used for, just cleaning some small surfaces and equipment. Contact time is just about 30 seconds. So what it means is that you don't just spray alcohol and then you just start cleaning. You spray, you leave it for some time, and then you do the cleaning. Or if you also spray, you may just want to spread it on the surface so that it will cover the full place you want to disinfect. Leave for some 30 seconds, and then you now use a dryer, tissue or towel to clean it off. Yes, and it's moderately expensive. Then you have the quaternary ammonium compounds. And these are, for example, this Izal, what we call Izal and all that. And then you also have the hydrogen peroxide, which is also used to clean various surfaces and equipment. And the contact time is 5 to 10 minutes. It's also moderately costly. Now, when it comes to the bleach, we need to know, how much we should prepare, the concentration we should prepare. So for general surfaces, you can use the 0.05%, but then for blood spills, you have to prepare the 0.5%. And in case you don't know how to prepare these, you can contact Adiz. I'm sure she will teach you. All right. So why chlorine for Ghana? Because it's the cheapest disinfectant available and it's effective against many pathogens, and it's also widely available. Yes, when you go to the supermarkets and you want to buy bleach, it is all just chlorine. So it is recommended by the WHO as well as the Ghana Health Service. So when it comes to some safety issues, you should never mix your bleach with acids or ammonia gas or even your detergents. And then you should use it in ventilated areas, and it should be prepared fresh daily. If we say fresh daily, what we mean is that it's not the concentrated one we are talking about, but when you dilute it to use, you need to use it quickly because it will wear off, its strength will wear off quickly. And you should store them in opaque and labeled containers. And make sure you wear gloves when you are handling the concentrated bleach. Now we move on to blood and body fluids spill management. So we want to look at the standard operating procedure for spills. So for small spills, which we say the volume of the spill is less than 10 mils, you first of all have to put on your PPE and then you confine the spill. So here you can cover it with an absorbent material and then you disinfect. In this case, 0.5%. You wait for the 10 minutes contact time, then you clean up with either a wipe and then or a tissue, and then you just dispose in a biohazard waste container. And then you should clean the area again, but this time around with a 0.05 chlorine. And then you remove your PPE in the proper way, perform hand hygiene. Now for the larger spills, you have to first of all clear the area, as in get people away from the area. And then you don your full PPE. So you put on the heavy duty gloves, the gown, boots, and then boots if they are available. And then also the face shield. And then you also make sure you absorb the bulk of whatever has been spilled. So here you use absorbent granules or paper towels. And then you also disinfect liberally using your 0.5% chlorine solution by flooding the area, and then you wait for 10 minutes and then you clean. By cleaning, you should mop from the outside towards the center. And then you dispose all materials as infectious waste. We'll look at waste soon. And then you do the final disinfection using your 0.05 chlorine. You remove your PPEs carefully and you perform your hand hygiene. So we now want to look at some special considerations. So if your spill contains some sharps, you need to use some forceps or tongs to take those sharps out. You should never use your hand to pick them. And then you should place the sharps in the sharps container first, and then you proceed with your spiller. If it's on a carpet or any other kind of upholstery, blot, but don't rub with the 0.5% chlorine. You know that when you are blotting, what it means is that you allow the chlorine to seep into the material, and then you can just absorb it with whatever cleaning material you have, the wipe. And then sometimes you may need to employ steam cleaning. But if it's too heavily contaminated, just consider replacing it. Now, every department should have what we also call a spill kit. And this spill kit should contain things like the heavy duty gloves, apron gowns, face shields, absorbent material, your 0.5% chlorine solution. You can also have the powder, which you can dilute. And then you can also have some biohazard bags in there, a scoop and scraper, as well as some warning signs. For example, spill, do not enter. So then we want to look at healthcare waste management in Ghana. So we have waste categories according to the Ghana Environmental Protection Agency as well as the WHO. So we have the general waste, which are non-hazardous, and the color of the waste bin or container or receptacle is black. Then we have the infectious or pathological waste. That one is yellow bag or bin. And usually this is the most dangerous waste category. Then you have the sharps. Usually that would be in a puncture-proof yellow container. And then you have your chemical or pharmaceutical waste, which is usually placed in a brown bag or bin. And then a radioactive waste usually has a lead-lined container. And this one is a special kind of waste. Now, it's also important to note that wherever the waste is being produced, you need to perform waste segregation at that very point. And it should be done there and then, not later. Because usually when you leave it for later, you can expose others to that danger. But there are some common segregation errors. So here we end up mixing, the various types of waste. And that would mean that you end up making all the other waste in that particular receptacle hazardous. And if you also put general waste in yellow bags, you are just wasting the yellow bags. And you should not also put sharps in regular bags because someone will end up with a needle stick injury. And then you shouldn't also overfill the containers. Usually the container should be filled 3/3 full, 3/4 full. And then also, it's very unsafe not to label your bags or your waste bins because it will create confusion. Sometimes that means you will have to go into the bag and try sorting them out. So we also have some statistics for Ghana when it comes to our waste categories and management. So the hospitals in Ghana per bed per day produce about 0.5 to 2 kg of waste. But then only 30 to 40% of our facilities have proper segregation. And there's also the problem of improper disposal. And so this really affects those communities which are around those dump sites. And the economic impact is that we end up treating all waste as infectious. And that costs us about 5 to 10 times more. Now I want to talk about, profession-specific IPC applications. Profession-specific IPC applications. So I'll start with the medical laboratory sciences. So some of the key, IPC practices for lab scientists is that when it comes to specimen handling, all specimens have to be considered as potentially infectious, and those should be worn for all specimens. And biological safety cabinets are to be used for all high-risk procedures. There should be no eating, drinking, applying cosmetics in the lab, and no mouth pipetting. And we also have very unique IPC, challenges in the laboratory. So for example, when it comes to spill management, laboratory spill kits should be readily accessible. And then there should be specific protocols for different specimen types. And there should also be chemical, against biological spill procedures. Then when it comes to centrifuge safety, there's a need to use, sealed rotors or safety caps. And then the balance or tubes that are placed in the centrifuge should be balanced properly. And you should allow, aerosols to settle at least 5 minutes before opening your centrifuge. And then you should clean and disinfect the rotors regularly. When it comes to microscopy, you need to disinfect the stage, between specimens. And then also dispose of used slides properly and clean the objectives with appropriate solutions. When it comes to waste management, you need to decontaminate cultures before disposal by autoclaving them. And then you should also place sharps in the designated containers at each workstation. And when there is chemical waste, they should be segregated properly and labeled. Now, we also have some post-analytical, IPC challenges. And this includes disinfecting the workbenches at the end of your shift. You should clean any kind of shared equipment, whether they are analyzers, microscopes, when you close or you finish using them. And then you should perform hand hygiene before leaving the laboratory. Then we also have TB lab, safety. This one, special focus for Ghana. So N95, respirators are mandatory. And negative pressure rooms are preferred. And it's also important to use UV, germicidal lights. And then you should work in biosafety cabinets. And, personnel should be limited access to the area or the TB lab. And there should be annual TB screening for staff of the lab, especially when they carry out TB work within that place. Then it's also important to integrate, quality control. So IPC audits should be part of the laboratory, quality management system. And also, there should be, some skill response drills that should be carried out at least every quarter. And then there should also be, very good monitoring of the PPE stock. And hand hygiene compliance should also be tracked. Now we move on to the physiotherapists. So the physiotherapists also have unique IPC challenges. And these include, that close contact, physical contact with their patients, using shared equipment, and high patient volume in their OPDs, and then also, treatment of wounds and post-surgical patients, as well as some home visit exposures. So there are also key IPC practices for physiotherapists. So the first is about patient assessment. So there should be hand hygiene before and after each patient contact. There's a need to screen for infectious symptoms, whether the person is having like a fever, a cough, or a rash. And then you also check wound status if there's a wound present. And then you also review, some isolation precautions if the patient is hospitalized. Then when it comes to treatment sessions, in fact, you should use gloves for, wound care or handling soil linens. And you should also use aprons if there's a risk of body fluid contact. You should also cover any cuts or abrasions on your own hands. Okay, that is to avoid you also transferring something to a patient. And then you should also avoid, unnecessary touching of your face during treatment. That's when you are handling the patient. Then we come to equipment hygiene. So after each patient, at least you need to wipe, down all equipment with disinfectants, clean the mats, the therapy balls, and the weights. All these seem like it's a lot of work. But if we are very serious about infection prevention and control, then it should be done. Then on a daily basis, you also need to, do thorough cleaning of the treatment areas. You need to launder linens and towels, disinfect the plinth, as well as examination beds. And then on a weekly basis, you need to do a deep cleaning of the entire department. And then you also check integrity of equipment covers. Yes, our physiotherapists also do what we call hydrotherapy. So we want to look at hydrotherapy safety. So there's a need to, check the water quality or to monitor the water quality, at least check the chlorine levels, and then shower before entering the pool. And there should be no open wounds in the pool. And you should treat the pool water as, potentially infectious. And then clean the changing rooms between patients. Yes, we also perform home visits. Physiotherapists perform home visits. And so there are some home visit precautions. So you need to have a portable, hand or use portable hand hygiene like the alcohol-based hand glove. You should have disposable gloves in the bag. You should have portable equipment dedicated per patient when possible. You should also clean, equipment between home visits, and environmental assessments also should be done for hazards. And there are some, special considerations. So for post-surgical patients, you need to check their wound status. You need to use aseptic technique. For methicillin resistant Staphylococcus aureus, or for vancomycin resistant, patients, you need to be cautious, or you need to take precautions when you are contacting them. Use gloves, use your gown. If you are dealing with TB patients, you may need to be in your N95 respirator. You may need to also limit your treatment duration. And then if the person has, respiratory infections, you have to be in your surgical mask, and you also have to, be very conscious about your hand hygiene practices. Then when it comes to documentation, always note, the infection control measures that are taken, report signs of infection to the medical team, and then document equipment cleaning as well. We move on to radiographers. So radiographers also have some unique IPC, challenges. So for them, their equipment are difficult to disinfect because you can't immerse them in, the disinfecting solution. And also there are emergency procedures which limits time for full precautions to be, taken. And then also the portable X-ray in isolation rooms. Also contrast media injection, which, in this case, is an invasive procedure. And then they have high patient throughputs, or like they have many patients visiting, their place. So some of the IPC practices for radiographers, include some of their standard procedures, which should, like they need to perform hand hygiene, wear gloves, disinfect equipment between patients, etc. Okay. Then also they need to disinfect equipment such as the X-ray table, the ultrasound probes, the CT or MRI, patient's couch. They need to also clean the positioning aids. Now, when it comes to the portable X-ray in isolation rooms, they need to review patient precautions before entry. They need to, wear the appropriate PPE before entering, and use disposable cassette covers, doff the PPE correctly upon exits, among others. Then when it comes to fluoroscopy and interventional radiology, they also need to, employ sterile technique for vascular access, and they also need to use appropriate PPE for procedures. They need to do proper sharps disposal, and then also disinfect the fluoroscopy equipment. For ultrasound infection control, transducer covers for all invasive producers. And then they also need to use high-level disinfection for transvaginal stroke transrectal probes. And then also, if they need to use external probes, they need to carry out low-level disinfection. And then when it comes to the gel warming units, It should also be regularly cleaned against bacterial growth risk. And then it's also better to use single-use, gel packets. So it goes on and on. MRI, CT, contrast media, special patient populations. Yes, with respect to special patient population precautions. So if it's a TB patient, they need to use the N95 respirator, and they all have to also limit the time they spend with the patients inside the room where they are carrying out the procedure. And they also have to make sure that there's adequate ventilation in the place. If it's someone who has Clostridium difficile infection, they also have to be careful about contact with the person. And then also they need to disinfect for spores, because Clostridium difficile produces spores, which are mainly the route of transmission. So it's airborne. So they have to be careful about that. Then when it comes to immunocompromised patients, they also need to, make sure the environment is well protected and there's limited exposure for these patients. And they also have the issue or the challenge of, having to manage their waiting area, because they also have a very large patient population. So if there are patients who are coughing, they should be given masks. And then there should also be, some spatial separation. And they should also be constantly reminding their clients about hand hygiene. And then they should disinfect chairs and the surfaces, other surfaces, regularly. Now, our dietitians and nutritionists also have their own unique IPC challenges. So, as for example, when it comes to handling food or preparing food, and then visiting multiple patients' rooms, assessing immunocompromised patients, kitchen or food service area hygiene, and then tube feeding preparation and administration. So they also have, some practices when it comes to, some patients' assessment visits. And all these are things that should be clearly, defined for proper IPC management. And, our dietitians also sometimes use stethoscope, and they need to clean the stethoscope, especially if they are using it to listen to the bowel sounds between patients. So from one patient to the other, they need to at least also disinfect or clean their stethoscope. And as well as all the other general precautions using PPEs should be followed. And then when it comes to food safety or the food service safety, when it comes to the food handlers, at least there should be an annual health screening and exclusion policy when someone is ill. And then kitchen hygiene, there should be proper hand washing facilities, there should be clean uniforms or protective clothing, hair restraints, no jewelry, no open wounds. If someone has an open wound, the person should be excluded from working. And then when it comes to food safety too, there should be safe storage temperatures, cold and hot. And then they should also do well to prevent cross-contamination. Especially, they should separate raw food from cooked food. And then they should also employ the proper cooking temperatures. And then when some foods are left, there should be rapid cooling of such leftovers. Then we have special diets, and infection control. So we have some patients who are immunocompromised. So we have to make sure that such patients have low bacterial diets so that their situation is not aggravated. And then there are patients who have to be given feeding through tubes. So that one, so the preparation area should be clean and it should be a dedicated space. If it's to do with, formula handling, there should be closed systems, there should be, hang time limits, and there should be, change feeding bags and tubing per protocol. And aseptic techniques should be used. Storage should also be well controlled. Now, they also use various trays. So they have their diet trays and other services. So these trays should be clean, and put in very clean assembly areas. The hands should be washed before handling the clean trays. Food coverage should be employed during, transporting of the food to the ward, you know, and if any food is returned, that returned food or item should not be reused. And then patients on isolation should, they should use disposable servicewares for patients who are in isolation. Then we also have the nutrition office or counseling room. So that place should be clean between patient appointments, hand hygiene before and after patient contact. They should disinfect the shared items like the food models and the measuring tools that they employ, the handy measures and all that. They should be clean. And then also the educational material should also be wiped clean. Especially if they are surfaces, they should be wiped clean. So when we come to Ghana, we also have some specific considerations. So we have food vendor hygiene. So we need to educate families on food, safe food brought from home. And then when it comes to our traditional foods too, we should assess the preparation safety. And then when it comes to breastfeeding, support as safest nutrition for infants, even with maternal infections like HIV, on antiretroviral treatments. As in, we need to support breastfeeding women who may have some of these infectious diseases so that the children can be protected. So last but not least, we look at the speech therapist and audiologist. So they too have unique IPC challenges because they come face to face, or they usually are close face to face with the patients, and they are exposed to droplets. And then sometimes they have to carry out oral and nasal examinations, and all these still expose them. And then also there are procedures that they carry out and involves the patient having to swallow. So they carry out swallowing assessments, and this can expose them to saliva. And then they also use some therapy materials which are shared between patients. And then some also work with, vulnerable populations, children, and then the elderly. So there are also key IPC practices. This time around, we are focusing on the speech therapists. So they also have, various sessions that they carry out with their patients. So when it comes to assessment and therapy sessions, there should always be hand hygiene before and after each patient. Gloves are mandatory for oral examinations. They need to consider face shield for procedures generating droplets. So we have these oral motor exercises. If they are going to carry out something like that, they need to put on the face shield. And then at least they should sit at 90 degrees angle to patients when possible, not face to face. Then they also have, oral examination on dysphagia assessments. So that one, they should always be in gloves. They should consider mask and eye protection. They should also have tissues available. They should have tongue depressors, single-use ones, and they should be disposed immediately. And then also, they should have mirror examination tools. And these ones can be heat sterilized, or they can be the disposable types. Then there are various therapy materials for them, toys and various objects, picture cards, books, mirrors, electronic devices, etc. So as much as possible, for toys and objects, they should be cleaned with soap and water after each use, and they can be disinfected weekly, with appropriate solution. When it comes to the picture cards or books, they can, be laminated so that the faces can be wipeable, and then they can be cleaned. And then they should also be disinfected between patients. And then paper materials should also be dedicated per patient, or they should be the disposable type. If it is mirrors, they should be cleaned and disinfected between patients. If it is these tablets or electronic devices, they should be wiped with disinfectants also between patients. And then there are special considerations: pediatrics patients, ventilator patients, and tracheostomy patients. So for pediatric patients, children may drool, especially when they have objects in their mouth. So there should be extra emphasis on toy hygiene, and there should be use of gloves when handling mouthed objects. And then also there should be parent education on not sharing toys in the waiting room. With the ventilator patients, there should be full PPE wear, as well as, coordinating with the nurses when it comes to suctioning. For the tracheostomy patients, gloves should be worn, possibly eye protection should be worn, and then there should be strict hand hygiene. Yes, our speech therapists also perform home visits. So they can have their alcohol-based hand grab, disposable gloves. They should carry along minimal therapy materials, and they should clean materials between home visits and educate families on toy, cleaning. Then we end with the audiologists. Yes. So for the audiologists, they also have their key IPC practices. So when it comes to equipment disinfection, which is very critical, for example, when it comes to otoscopy, they should use disposable spatula, which is usually a single use. If it is reusable, they should clean and use high-level disinfection between patients. They should also disinfect the otoscope, handle daily. Then you have the audiometry headphones and insets. So you have the supraoral headphones. These ones have disposable covers or alcohol wipe between patients. And then the inset earphones, those ones use single foam tips. So after the patient uses the particular earphone, you remove the foam tip and replace it with a new foam tip. And then it's also, using the bone conduction oscillator. That one can be disinfected between patients. Then we also have tympanometry probe tips. So you can also use disposable ones if preferred. If you want to use a reusable type, wash and then use high-level disinfection. There are also hearing aids. So gloves should be used for patients when handling patients' hearing aids, and they should be disinfected after handling. And then you should also educate patients on daily cleaning. Then we also have sound booth hygiene. So you need to ventilate between patients, disinfect high-touch surfaces like the door handle, chair, response button, etc. And then the windows should also be cleaned weekly. Cerumen management, that's a brown substance that comes out of our ears. So use of gloves is mandatory. The ear should be irrigated, in a safe manner to avoid perforating the eardrums. And then also, if there is any extracted cerumen, it should be disposed of as an infectious waste. And then also, all instruments that are used should be disinfected after use. Then we have vestibular testing. So here you have to use disposable goggles, disposable goggle covers. And you should also disinfect between patients. And you should also prepare for, potential nausea or vomiting. And then gloves and apron should be in place should the patient vomit. And then there should be common thorough cleaning after the test. Of course, they also have special populations. So they may have some patients who have ear infections. So gloves and careful disposal of the contaminated materials. And then in case of immunocompromised patients, extra stringent disinfection protocols have to be employed. Now, we want to end today's session by looking at a multi-professional IPC scenario. A multi-professional IPC scenario. So ideally, if not for our time, this was something that would be an exercise for us to discuss, but due to our time, we will just walk through it quickly. So in a district hospital within the eastern region of Ghana, over 2 weeks, 5 patients on the surgical ward developed post-operative wound infections with similar symptoms. So there was fever, purulent discharge, and delayed healing. And all had different surgical procedures. So here there was an appendectomy, hernia repair, cesarean section. So the infection control team was called in to investigate. So here are the patient details. So patient A is a 35-year-old female who had a cesarean section, and it has been 5 days after the cesarean section. Patient B is a 28-year-old male who has had an appendectomy, and that's 4 days post-operation. Then patient C is a 52-year-old male who had a hernia repair, and that's been 6 days after the procedure. Patient D is a 41-year-old female who had a cholecystectomy. That is 3 days post-operation. And then the last one is a 29-year-old female who had a cesarean section. So some wound cultures were carried out at the lab, and it showed the presence of methicillin-resistant Staphylococcus aureus. So what do we think are some of the IPC failures? So here we would have broken into some groups to discuss. So the questions for us is that, so what IPC breaches could have caused this outbreak? And then what is your profession's role in this investigation? And then what immediate actions should be taken? How can we prevent this from happening again? So the possible IPC failures are that compliance with hand hygiene, procedures was inadequate. Surgical equipment were not sterilized, and so they were contaminated. And then the environment was also contaminated due to inadequate disinfection of ward surfaces and equipment. And there can also be, a health worker who was carrying this methicillin-resistant Staphylococcus aureus, in the nose. And then it could also be that there was a poor wound care, or the technique for the wound care was substandard. It could also be that some shared equipment were not properly disinfected. So now we want to look at some multi-professional responses, starting from to help with this particular situation. So the first is the medical laboratory scientists. They would collect and process all the wound cultures. Then they also do sampling of the environment. So the operating room surfaces, the equipment. They also screen the various healthcare workers for the methicillin-resistant Staphylococcus aureus colonization. And then they will perform antimicrobial susceptibility testing. And this is meant to be able to find which antibiotic can naturally kill the organism that has been identified. And then they will also monitor for additional cases, and that will be surveillance. On the part of the physiotherapists, they would also review mobilization protocols. But in this case, they will be avoiding any kind of wound contamination. And then they also ensure that equipment are properly disinfected. And then also, they would also insist that patients should be screened before they are treated. And then they also reinforce hand hygiene practices. So these are things that are being contributed by various allied health professionals to make sure that this particular situation that occurred will not occur again. Now, for the radiographers, if the patient needs some imaging to be conducted, they would ensure that the portable equipment that are used for the imaging, that is, if the patient cannot be sent to their department, those portable equipment are properly disinfected. And then also, they would also go further to review all their protocols for imaging infected patients. On the part of the dietitians, they would also review their mobilization protocols to make sure that they will avoid, wound contamination. And then also, they also ensure that all their equipment are properly, disinfected. And then also, they will screen patients before treatment and then reinforce hand hygiene. And then for the speech therapists, in case they are involved, they are also going to review, how they treat their post-op patients, especially when it comes to aspiration risk, because this could affect the wound healing. And then they also ensure that therapy equipment are properly disinfected. So together, all these professions are reviewing and reinforcing their IPC protocols. They are also participating in root cause analysis. They are implementing enhanced precautions, and they are documenting all patient contacts. And they are as well supporting, contact precautions for all infected patients. So the outcome here is that the investigation revealed that the operating room environment, contamination plus the healthcare worker who was a carrier for the healthcare worker who was a carrier for the methicillin-resistant Staph aureus plus suboptimal hygiene contributed to the infection that was spread, the MRSA infection that was spread. So together, all the actions that they took can be summarized as follows. They were able to enhance the operating room cleaning protocols. Now they also were screening healthcare workers and also making sure that with that, they are bringing about decolonization. And then also making sure that audits become mandatory for hand hygiene. And then also making sure that anytime they are handling a patient who has methicillin-resistant Staphylococcus aureus, they employ all the needed precautions. And then finally, they were also involved in staff retraining on the use of their PPEs and then aseptic technique. So after putting in all these measures, they were no more recording new cases of this particular methicillin-resistant Staphylococcus aureus. So this is showing a team approach to solving or mitigating or preventing infections from occurring within their facility. So in conclusion, we can say that together we are the frontline defense against infections. And through our unified commitments, our consistent practices and shared vigilance, we protect every patient, our colleagues, and the community we serve. So here we have one team, one mission. And our mission is that we want safer healthcare for all. Thank you very much. So at this juncture, I would take any suggestions, comments, or questions.
Okay, thank you so much for the wonderful presentation. Let me unmute everybody so that they can get to speak. So you have the right to unmute and speak if you have any question. Okay, so I think everybody is okay without any questions. So thank you so much. So this we've come to the end of the training session. So all documents will be shared with you once we receive it from the facilitators. And also all the sessions will be uploaded on YouTube. Latest by Monday, you should have all of the sessions on our YouTube. All sessions will be on our YouTube channel. So thank you all for joining. I must say this session has been really a productive one because I really like this session because he used a lot of practical ways to which most of us could relate. So thank you all for having this. I'll say bye bye for now. If you can show your video, then we'll just take a quick snapshot, then we'll end the session for 2025. It would be good to have your cameras on. We have our picture, then we would end the session. Okay. Okay, wonderful. Wonderful. Okay, so we are waiting for more of you. I can see your make. I can see Brady, Jessica, Ajete, Lucia, Banawu, Barakisu, everybody. Please, we are just going to take a snapshot, then we would end the session. Okay. You can see me. So please smile like you are happy, even if you are not happy. Oh, it's good to see Mr. Allotey. Okay, so I will do this. Kingsley, please, are you ready? Okay, okay, perfect. Okay, thank you all for joining. Thank you all for joining. Thank you all for joining once again. So all of the sessions will be uploaded, as I said. All of the sessions are recorded, as you know. So we're putting it on our YouTube platform where those that haven't been able to join the sessions will have to go there and get to access the sessions as well. And yeah, I think that's all for this 2025. So we have collated all of the list for the points. You would, latest by Monday, the points should be uploaded on your platform. So by Monday, when you check your portal, all of the points should be there. And yeah, I think that's all, everybody. Thank you so much for being part of 2025. I hope we see each other again in 2026. Bye-bye, everyone.
Amen. Bye bye. Thank you very much, Lisa.
Welcome.
Yeah. Bye.